to this computer. Uh, Hello, everyone, and thank you for joining us again for our continuing series on trauma-informed care. Today, we have with us Dr. Joseph Boffa, who is a suicide specialist at the VA facility here in New Orleans, and he's going to speak to us about suicide prevention, especially the end of life. So, Dr. Boffa, thank you for being with us today, and the floor is yours.
Well, thank you very much for having me. This is an excellent opportunity, not only to get some of our knowledge and education out there, but primarily during Suicide Prevention Awareness Month. This is a topic that is always on the minds of us here at VA, but I think is something that is very pertinent for people all across the board, no matter where you are, and something that we hope will be helpful for the very important work that y'all are doing. Want to just kind of start off, instead of setting an agenda per se, want to kind of just orient everyone to the VA's sort of framework for talking about how we can sort of build our understanding and awareness of suicide prevention, some of the warning signs, and then the steps that we can take to help individuals who may be experiencing thoughts about suicide. So this is going to kind of guide our conversation today. It's been termed the SAVE approach, that acronym standing for trying to understand what the signs of suicidal thinking are and how to recognize them. Learning to ask about suicide risk in different individuals in a very nuanced way. And then validating the experience of the person that we're talking to, and moving into providing some encouragement, some hope, and expediting their ability to get to care. So that's going to be the framework that guides us today and our conversation here, while we address some more specifics that I think kind of talk a little bit about veterans, also hospice care, and individuals who are incarcerated. So we'll start with understanding suicide and just kind of the scope of the problem. Suicide is currently the 12th leading cause of death, used to be ranked as high as 10th before the pandemic, and typically accounts for just a little under 50,000 deaths annually in the United States. As you can see from this graph, the rates of suicide have increased almost year over year for about the last 20 years, which was when we really started keeping close tabs on the rates and figures related to suicide deaths. As you can see here too, rates of suicide tend to be higher in males compared to females. And when you average those things out, we have in the last year that we have full data for, 2021, a rate of about 14 deaths by suicide for every 100,000 people in the United States. So while we have kind of been doing a better job tracking and understanding who's dying by suicide, that's also kind of given us a better idea that this has become an increasingly growing problem, kind of across the board, no matter who you are. So we also are aware that about 2 to 5% of the US population in general has thoughts about suicide at any given year. And just to kind of put that in perspective, that would be anywhere between about 60,000 and 100,000 people per year. A small percentage of those do end up moving from just thinking about suicide to attempting suicide. And so that would be something where they're actively engaging in a behavior that could result in injury that has the potential to be fatal and end their life. So although we have a large number of people who are thinking about suicide, only a small portion of those end up transitioning to acting on those thoughts and doing something that may end their life. And And oftentimes, the injuries that people sustain from those attempts aren't actually fatal. It may hospitalize them, it may injure them, but it doesn't always result in death. And so tends to see kind of this funnel effect where we have a lot of people thinking about suicide. Some of those people acting on those thoughts and doing things in an attempt to end their life, and then just a smaller portion of those folks actually end up losing their lives. One of the reasons that it's important to kind of highlight this is that suicide is preventable. So just because someone's thinking about suicide doesn't mean that they're going to attempt, but it does mean that there is an opportunity there for us to be able to provide some kind of care and intervention that can help to keep them from getting to the point where they are thinking about ways where specifically they can attempt suicide. So part of our focus as suicide prevention advocates is to bring awareness to the issue, and also to encourage productive conversations about suicide and suicide-related risk with anyone and everyone that we can. So while we can't always know what others are thinking, many times people are pretty good at hiding their thoughts from us, particularly those about suicide. The more that we continue to talk about it, the easier it's going to be to intervene and provide help to those who are thinking about suicide before they transition into being someone who thinks about a specific way and then has the ability to take some action to end their life. So just to kind of give you a scope of the problem among certain populations that might be relevant to us, this is a little apples to oranges because there are differences in men and women in terms of suicide rates. So we saw that graph earlier where men have higher rates of suicide than women do. And the numbers you see here aren't adjusted for that gender difference. So they look a little bit inflated. But if we adjust for gender, the raw numbers are going to be lower. Like that number 32 is going to kind of come down, but the same pattern will tend to be kind of the same. So we see the highest rate, at least kind of locally here. Louisiana and Mississippi have some of the highest rates of veteran suicide in the country. That's in part due to the large number of firearm ownership here, because most veteran suicides occur by firearms. About 70% of them do. Firearm ownership among veterans is much higher in the southern rural states than it tends to be in other areas of the country. And so we do tend to see higher rates of suicide among our veterans locally here. Across the board, too, veterans just tend to have a higher rate of suicide compared to civilians. And we don't really have great data about suicide among individuals who are either in jail, state prisons, or federal prisons. It seems like those different complexities tend to kind of change the rates a little bit based on the setting. And the numbers kind of like have a very wide range at this point because we haven't really done enough of a job in research to kind of figure out what those numbers look like real specifically. But it seems to be that the rate of suicide among state prisoners tends to be between 12 to 20%. So it's looking kind of a little bit like civilians, maybe a bit elevated there comparatively. Just speaking specifically about veterans, we do have it's estimated about 200,000 veterans who are incarcerated in state prisons across the country, or state, federal, and local prisons or jails any given time, any given year. And we know that the rates of suicidal ideation and attempts, so again, this includes everyone who's thinking about it, not necessarily just those who are making actions. That's estimated to occur for about 35% of our justice-involved veterans, which basically is, if you think about like 1 in 3 veterans who has experience with incarceration is experiencing at the very least thoughts about suicide. That's definitely much higher than the general population, where the rates tend to be around 10%. So we'll talk a little bit about why that may be in just a bit here, but to kind of put that in perspective, we have about 60,000 veterans every year who are at least thinking about suicide or maybe even engaging in some behaviors that could cause injury or end their life. in any given year. So we're going to move into understanding risk and what goes into those numbers a little bit here. But will also help us to kind of understand what we should be looking out for as suicide prevention advocates. We'll talk about each of these independently here, but the main message that we want to take away is there's no single cause for suicide. There's no one reason why anybody thinks about suicide or dies by suicide, but there are certain correlates, different factors that we can identify that might kind of up people's risk a little bit. And when you start to combine some of those and see more of them happening for an individual, that's when we really start to kind of see some red flags that are kind of raised. So the way that we break them down are between risk factors and warning signs. In terms of risk factors, these are things that increase the likelihood that someone might at some point experience a suicidal crisis. Warning signs on the other hand, are going to be things that indicate that a suicidal crisis has maybe already kind of begun, or might be starting to escalate and get worse. So just to kind of give an example outside this area, a risk factor for something like heart disease would include things like obesity, really high BMI, being a lifetime history of being a smoker, or knowing that someone in your family has a history of heart disease. On the other side, warning signs of something like a heart attack would include pain or physical discomfort in the chest, shortness of breath. So those risk factors are things that are kind of like, they aren't the thing that causes the heart attack. It's not exactly what's happening during the heart attack, but they're things that make people more likely to have a heart attack. Whereas the warning signs are saying someone's having a heart attack right now. And so we can kind of use that analogy with suicide here, where our risk factors are things that have happened in their life, or things that might be true about their mental status, that puts them at risk for at one day having a suicidal crisis, whereas the warning signs are things that are telling us this person's probably thinking about suicide, and maybe has some plans for action that we need to sort of intervene with. We'll start with secondary risk factors. These can help to kind of clarify someone's risk level, and give us some idea about ways that we might be able to kind of support them. One would be lack of meaningful social connection. So feeling like people don't have anyone that they can turn to or rely on, either around them physically or just kind of in their life that they can connect with over the phone or through writing. Recent stressful life events, particularly those that have occurred within the past year. Obviously, incarceration can be one of those things, especially if someone is recently incarcerated. But then, without that level of control and everything that's happening in your external life, that can also include the death or loss of a loved one, different issues with relationships that are ongoing, or arguments with significant others or spouses. Feelings of hopelessness, or believing that this is as good as it's gonna get for me, and it may in fact even get worse, and I just don't feel like things are really ever are going to get better. I can't change anything about that. I have no hope for a bright future, or any future at all, really. Can also be the presence of a psychiatric disorder. So some of the big ones that tend to put people at risk for suicide are depression, bipolar disorder, and trauma-related disorders as well. We talk a lot about stressful life events in the past year that might kind of lead someone to experiencing thoughts about suicide. Well, it may be the case, and oftentimes is, that when folks experience trauma, especially early on in life, that really puts them at risk for developing suicidal thoughts later. And we tend to see that start more often than not in the teenage years, or sort of like early adulthood, after turning 18, or after folks leave home, whenever that may be. A history of either interpersonal trauma, abuse from people around us or even people that we don't know, even something like just adverse experience in childhood. So if you were, hit as a child, or if you were in a household where there was a lot of yelling and verbal threats, or emotional neglect, if your basic needs weren't met, like you didn't have enough food, all of those things are traumas that uh, tend to put people at a disadvantage in terms of their mental status later in life. Can lead to things like depression, can lead to things like PTSD, and can also lead to things like feeling hopeless about the future and thinking about suicide as a way of escaping all of those problems that either existed for them at one time and they can't quite shake, or are still kind of ongoing in their life. Another thing is advanced age. We do tend to see rates of suicide higher in folks the older that they get, particularly white males. Um, we aren't fully sure of why this occurs, but one reason may tend to be that as we get older, we tend to kind of lose some of our social connections. Either the people around us are having to move away for different reasons. We're separated from them, not by choice. Maybe more of them are starting to pass on. And so because of that, this tends to sort of bring out, some low mood and depression, also sort of thoughts about hopelessness for your own future. So we do tend to see that rates of suicide are a bit higher among our older populations as well. Specific to veterans, some of the risk factors that we tend to see at a secondary level, again, white males, these tend to be younger, however. So we have veterans who are coming out of more recent conflicts that we tend to see more at risk for suicide. So, like I said, like OEF, OIF, OND, all of those conflicts in Iraq, Afghanistan, sort of the Middle East over the past 20 years. Also, folks that have served, particularly in the Army, seem to be more at risk. And those who have a history of trauma, particularly if it's combat trauma from any of these recent conflicts, those tend to be some of the warning, or some of the risk factors, I should say, that put people at risk for having suicidal thoughts or behaviors later on. This is obviously a little bit more pertinent to some of our folks here that we're working with at VA, but like I said earlier, 70% of veteran suicides occur by firearms, so firearm owners tend to be those who are most at risk. And then specific to some of our hospice patients, wanting to identify what are some of the risk factors for suicidal thoughts and behaviors. Chronic pain is a major one. Just being untreatable, seemingly, feeling like you're in pain all day, every day. That usually tends to lead to hopelessness. You might hear a lot of comments about, this pain just won't go away. I don't know what to do about it, but I want it to end. Those types of comments and thoughts are very common for our folks with chronic pain. And so therefore, a lot of times our folks who are on hospice care. We also see isolation and loneliness. As I mentioned, part of that may be due to being of advanced age, and feeling like some of your social connections have kind of fallen by the wayside or passed on. Part of that is just kind of the environment for care, whether or not there are as many people as before around to kind of provide some of that social interaction and engagement. And also just being unable to be with loved ones during that time can be very difficult. It's great if we're able to, get a letter or make a phone call, but it's difficult when they're not always there to comfort us and to kind of provide some of that encouragement and comfort. Another thing with our hospice patients is kind of dependent on the severity of their condition, but also the rapid, the rate at which their diagnosis kind of progresses. So oftentimes we tend to see that if their condition is kind of quickly declining, then that tends to kind of put them at greater risk for having these thoughts about suicide. Again, things are kind of outside their control. They just don't see that it's going to get better. They're, rightfully being told that it's looking like it won't get better. And that just kind of brings on a sense of hopelessness that can lead to some of those thoughts. Another thing that can cause some of the issues here related to social, not necessarily isolation, but kind of feeling socially disconnected from others, is this idea that we're a burden on other people. When depending on the need for level of care, there may be some patients who really are having a difficult time doing much of anything on their own. And that can lead to some of these thoughts that, I'm burdening other people. There's other people who need help worse than I do. Like this, I shouldn't be getting this attention. And I think that we all kind of recognize that's not necessarily true. This is a service that we want to provide to them. We find value in giving to these folks, and it's important to us, and they're important. But they don't always see it that way, and they don't always have those same thoughts that we do. So kind of listening in for some of those conversations too can be important as well. Focusing specifically on risk factors during incarceration, solitary confinement is definitely one. I don't know specifically if it's that if you've ever been in solitary confinement or if you've recently been in solitary, but this is something that tends to kind of it's a stressful event, right? So these stressors can lead to thoughts about suicide. It's I think kind of evident there why that might occur. Also victimization. So if people are being physically taken advantage of, physically abused, manipulated, all of those different ways that someone might become a victim, just kind of across the board, those types of stressors, again, stress, put people at risk for thoughts about suicide. Another is poor social support. So obviously we've talked a little bit about, this might include, your family, your extended network in the civilian population, but that can also include just poor social support in your immediate environment. Do you have folks that are, part of your gang that you can kind of hang out with and you have an opportunity to spend time with that can kind of lift you up and support you? Or do you feel like you're just kind of isolated? You don't really have people to kind of give you that support. And then also serving a life sentence. So this kind of then I think too gets back to that degree of hopelessness for the future. Feeling like nothing's really in my control. There's what's the point of being here? If people are kind of losing hope about their ability to improve their condition or do things of value to them and find value in the activities and the services that they're providing, that's when then people kind of start sliding into that low mood, some of the hopelessness, and maybe thoughts about suicide. We also see that conviction for violent offenses tends to be a risk factor for thoughts about suicide as well. Whether or not degree of violence necessarily plays into that, but oftentimes folks who are there's an overlap between our violence that we perpetrate and do on others and violence that we've experienced in our own lives. And so part of that, is the stress that's put on us and then the stress from a situation that we found ourselves in. And all those stressors combined can lead to low mood, hopelessness, thoughts about suicide. So all of these risk factors here, not to say that if someone has experienced these things, they're definitely going to think about suicide or they're definitely going to make any efforts to die by suicide. But it does put people at risk for it. And they're things that we want to kind of stay attuned for. So those are sort of the secondary things that have happened in our life, maybe not recently, but sort of, in the past that can put us at risk for suicide. The primary risk factors for suicide are going to be the more immediate things. They're things that are probably happening right now that we need to really pay attention for. And so one of those, even though this is a little bit of like recent past, but previous suicidal behavior is the strongest predictor of future suicidal behavior. Not everyone dies by suicide when they make an attempt. In fact, most people survive. The numbers are, closer to like 70, 80, 90% of people survive a suicide attempt, because they just aren't, they aren't lethal in terms of the injury that they receive. Most people who attempt suicide one time will not attempt suicide again. There are people, about 5 to 10% of people, who will continue to make suicide attempts, at least another one. But the majority of people do not attempt suicide a second time. And so that's, again, another reason why these conversations are so important. We want to try to keep people from attempting even once, because if we can, they'll still be alive. But again, then if they attempt again, or if they attempt a single time, we want to continue to have those conversations with them so that we can keep them from getting to a second attempt. So previous suicidal behavior is a primary risk factor that we really want to be aware of and pay attention for. Also, current suicidal thoughts. So we want to know if someone's having thoughts about suicide, because then that gives us a chance to provide some care, provide some encouragement, and keep people from getting to that point where they're making actions on those thoughts. And then we also want to, beyond that, people can have thoughts about suicide in terms of like, I wish I was dead. I wish I could kill myself. Starting to think about like, what are some ways that I could kill myself? Looking for things in the environment that you could use to attempt suicide. But then from there, even more importantly, we want to know about, okay, have you identified something specific that you would do to kill yourself? And have you started to kind of work out the details of how that would happen? So we want to know more about their plans, what they would use, how they would do it, what time of day they would do it, what would be the environment look like, what would they need to kind of be able to carry out that plan. We also want to know about intent, because people can kind of get to a point where they know what they would do, and they know when they would maybe have a chance to use it. It just hasn't really gotten to the point where they feel like they need to, or they really, really want to. And so asking questions about intent can be really important as well. One, because it gives us an idea of where people might be at kind of like a baseline, like just sort of every single day that I'm having these thoughts, I'm usually at like a 2 out of 10. And then if we're continuing to check in with folks about that, like, it seems like you're really having a hard time today. What's your number? Well, now today I'm at like a 6 or a 7. All right. Well, now we know that we really need to be, doing everything that we can to provide them with as much support as possible, because they're having a harder time. So those are kind of the more primary risk factors that we want to pay attention for. Now, like we talked about, warning signs are, as much as primary and secondary risk factors are important, warning signs are the things that we need to pay attention for, because they kind of signal danger in the immediate future. So we really want to kind of stay attuned to these and assess them, and kind of ask questions about them when we know that folks are having a hard time, when we notice that they're feeling a little bit more stressed and things like that. So we want to kind of pay attention for changes in agitation, so outward kind of behaviors or signs that they're feeling just kind of like keyed up, on edge, more hand wringing, some grimacing, maybe pacing, just something that looks like they can't calm down. Also, higher degrees of irritability, if people are a little bit more snappy, if they're quicker to anger and things like that. More social withdrawals. We might tend to see people who are kind of withdrawn socially, and maybe they're starting to, pull back even more. They're not really even talking to the people that they normally talk to on the day-to-day. They're very short in their responses. They just don't seem to respond to any questions, things like that. Also, noticing more depressed mood. Along with that, maybe more anxiety, statements about feeling more guilty, kind of tied to depressed mood. When folks are really depressed, we tend to see sleep disturbances. So they might have real bad insomnia. On the other hand, they might have, like they're sleeping way more than normal, and that's not necessarily just due to the medication that they're taking. And then it can also include, for folks with a history of trauma, things like nightmares, things like nighttime panic attacks. And so if they're complaining about bad sleep, kind of asking more questions about what that looks like and what is it that's getting in the way of the sleep. Particularly for our folks in hospice care, this can also start to look like either more refusal or just flat out refusal all of a sudden to continue to eat, continuing to take medications, continuing to drink water, basically taking care of their basic needs, doing the things that help them to function. This might be something that they're doing to kind of, part of that can sometimes come along with depressed mood. They just don't have the motivation to do it. But on the other hand, sometimes it's also a way for them to, in their mind, kind of bring about death a little bit more quickly, if that's what they're looking for. I think that sometimes we do see our folks in hospice care, kind of accept that they're coming to the end of their days. They've kind of come to peace with things, and they're, making statements like, I'm ready, I'm okay with that. And then sometimes it gets to this other place, a little bit deeper and darker, in the aspects of suicidality, where they're trying to actively do things to bring this on, and make it happen in a really quick way. That might also include, asking about anything that the doctors can do to help kind of bring this process on. So if any of those conversations start to happen, that's kind of a sign that someone's struggling, and maybe we need to ask about other ways that we can kind of help provide them with some comfort or support. So now that we have discussed what to look for, that's the S, or the signs of suicide, in that VA SAVE acronym, we're going to kind of move into what to do in these situations if some of the warning signs and risk factors are things that we're kind of identifying in the people that we're working with. So as we discussed, a lot of the secondary and primary risk factors you might kind of be able to identify without having to talk to somebody or ask any questions. You can just sort of observe those, or maybe it's come up in conversation like way in the past. You sort of just know this about the person. Many of the warning signs you can also identify without asking anything about. But the most important questions of all, really more of those primary risk factors, have to come from conversation. Those conversations are going to have to start with the most important question of all, which is, have you been thinking about killing yourself? Have you been thinking about suicide? As you continue to identify more of those risk factors and more of those warning signs about a patient, you might have a conversation that invites them to kind of describe the way that they're feeling. And if they voice some of those things that we've talked about today, this is an important question to consider asking. It's not an easy one to ask. It's never an easy conversation to have. It's very likely going to be uncomfortable. And I'll say from my experience and like 10 years of doing this, it doesn't really get easier. It stays difficult. You get better at just asking it, though. And that's really the important part, because it allows you to open that door for conversation. And I think that when you're working with somebody real closely, this isn't a question that is easy to ask and might not invite any kind of honesty if you're asking like right off the bat, before you really get a chance to work with them and get to know them. But if you have a bit of time to kind of build up a relationship with them, I'm not talking necessarily months and years, but you kind of get a little bit of rapport, and you guys kind of get along. This is one that, if you notice some of those warning signs, especially, can be an important question to ask. and something that you can kind of invite them into a conversation about. So in terms of asking about suicidality and thoughts about suicide, essentially just going to kind of go back to that list of primary risk factors. So we want to know about whether or not someone has made any efforts to die by suicide in the recent past. If not in the recent past, have they ever done that in their life? Because if they have, that kind of puts them at risk again. And then we also want to know about how, if they're having thoughts about suicide, how often they're having them. We want to ask about intent. So like we talked about before, getting a baseline and then kind of understanding where people are on the day-to-day. How strongly do you intend to kill yourself today? Just based on all the stuff that you're going through. That 0 to 10 scale can really be helpful for doing that. And then also wanting to know, if you're having thoughts about suicide, have you thought about ways that you might do that? Have you identified something specific? Where is that? Do you have access to it? Do you know when you would maybe try to do that? Asking questions about that, it can be really important. One, for knowing someone's level of risk, but also two, making sure that we're keeping the environment safe for them, to provide them as much support as possible and not giving them access to things that they could hurt themselves with. So the little acronym that we have for this is TIP. So times attempted, ideation, intent, plans, and preparation. Just a little tip to try and remember all the things that can be handy to ask folks about if we notice these warning signs. The V in that VA SAVE acronym is going to stand for validate their experience. So it's not an easy conversation to have, not for you, not for them. And I think one of the reasons that folks don't tend to want to disclose their thoughts of suicide to other people is that there's a stigma around it, and they worry about how we're going to respond. They don't want to make us uncomfortable. They worry that we're going to, criticize them for having those thoughts, or we're just not going to be helpful with our response to it. We're just going to tell them, well, okay, you need to do X, Y, and Z then, rather than just trying to be there to offer some support. Some ways that you can validate their experience is first by just talking openly about suicide. Essentially, not responding with shock, not trying to change the subject right away, but just kind of giving them the space to open up and be honest with you. That includes being willing to listen and just sort of sitting with some of those uncomfortable silences, which can be hard. I think that when we experience silence, our instinct is to try and fill it. And these are situations where we maybe just want to kind of be a little bit more reserved and give them the opportunity to open up without us really kind of forcing the issue. So along with that is, recognizing the situation is serious, not trying to make light of it necessarily. If you feel like you have that rapport with someone, maybe there's time for humor to kind of be brought in, but maybe not right away. Maybe this is kind of an opportunity to just kind of show like, oh, okay, I'm not going to freak out about that, but that really sounds like a problem for you. You tell me a little bit more about that. Like this is something we should talk about. I want to know, and I want to know how to be able to help you. The other thing, like I said, is to try not to pass judgment. People are oftentimes afraid of what we're going to think and how we're going to respond in these situations. And so we want to do our best not to kind of communicate any judgments or preconceived notions that we might have about them or about folks who think about suicide in general. Another important thing for validating their experience is to reassure them that they're not alone in this. By being willing to have that conversation with them and stay by their side, you can do that. Essentially, we want to just kind of give them the support that they deserve, and communicate this message that they're not alone. Other people are here for them. Even with these very difficult things, we can help. The E in this SAVE acronym then stands for encouraging conversation, expediting help. I think it also kind of reflects empathy. So we've touched on some of these a little bit, but essentially we want to remain calm. We want to do our best to maintain eye contact, to communicate that they have our attention. We're taking this very seriously, and we care about them. And doing this with confidence. So not getting skittish, not panicking about the things that they're saying and how scary they might actually be. Not trying to argue with them or, that can be invalidating. Trying to describe all the ways why they shouldn't be having these thoughts. People are having them for a reason, and we want to acknowledge that they're valid. And if we don't, it's not going to encourage any future conversation about it. Some things that you can do to do that also are just kind of using open body language, remaining present with them, facing forward, using eye contact, listening more than you're speaking. So kind of providing them the opportunity and the space to tell you a little bit more and kind of open up. That can be very cathartic for them to be able to finally let it out, and let someone know what they've been dealing with all this time. So we want to kind of limit our questions and let them do more of the talking. We do want to be honest. We don't want to, like I said, it's kind of invalidating when we try to, oh, well, things will get better, or like it's not that bad. We want to sort of acknowledge and be honest about the fact that, these are some scary thoughts and they are going through a lot, which might kind of explain why they're having them. And we can't necessarily just get rid of those right away. We can't get rid of the pain altogether. But there are people around them who are willing to help them. They want to help them, and they'll do everything that they can to provide those services. So along with that, just kind of trying to be supportive and comforting in your comments. And one of the most important things, I think, is to ask if there's something more that you can do to help. You're already doing a lot. But maybe they have something specific in mind that they don't want to ask about because they don't want to burden you, or no one's really stopped to ask what else can be done. It's a lot of the very direct questions of like, can I do this for you? And so kind of opening up that open-ended question of what more can I do to help you with this specifically, or anything else that might kind of relieve some of the stress that you're under. I'm willing here to do it. So those are some I think some recommendations and just sort of some strategies for how to have those very difficult conversations once you identify some of the risk factors and warning signs for someone. What we want to do then is think a little bit too about how we can kind of continue to be helpful. Part of that conversation might be talking about, out here we call a VA, this is a safety plan. It's essentially kind of used primarily in the context of, if you're having thoughts about suicide, what can you do to keep yourself safe? But really, a lot of these things that people end up talking about are just sort of like, when you're feeling bad, what do you do to help? And so I think it can be used in context, even outside of when someone's thinking about suicide. Just if your pain's getting too bad, what's something that might help change your mood a little bit? If your discomfort or your fear about what's coming next is too bad, what can you do to help yourself feel a little bit better? And oftentimes when we're under that stress of pain, of fear, we're not really thinking with our whole brain. We're having a hard time kind of problem solving or thinking back to like, okay, what were things that I used to do to kind of help myself in these situations before? It's difficult to have those thoughts and kind of think through those in a sort of like a logical chain of events. And so something like this can be helpful for just sort of like a go-to list of things that I can do. You can just get a scratch sheet of paper and have people kind of write these things down. But that will kind of increase the likelihood that people start to go back to finding coping skills that can kind of help them when they're having a hard day. So it's mostly helpful activities that make them feel better. It can be social supports that we're going to want to turn to, and then alternatives to suicide if they are in fact having thoughts about that. Like I said, it just kind of helps to make decisions a little bit more quickly and a bit more efficiently. We want to kind of help provide people with solutions for the distress that they're under, rather than focusing on just how bad the distress is. And we want it to be a living document. So what that means is that this can change over time. Maybe there's new things that they remember. Oh yeah, this could be helpful too. All right, well, let's add that to the list as well. It can be changing depending on the context and depending on what people tend to find helpful. Because if things that they write down initially aren't helpful, then we don't want that on there anymore. Let's go to something else and let's find another strategy. And we, can maybe kind of have conversations with them too about like, okay, how you feeling today? Not great. All right. Well, what have you done to help yourself feel better? We had that list of things. Was there anything that you tried? No. Okay. Well, what got in the way of trying? Is there something that stopped you from doing that? If there was, what can we do to make that easier for you to try and engage in some of these activities, or, have a conversation with someone just to kind of help lighten the mood and that sort of thing. So in terms of how to strategize with them for something like this, one thing that can be helpful is to first ask them like, well, what are some of the warning signs that you're feeling down, that you're feeling depressed, that you're having thoughts about suicide? What are the things that kind of tell you that you're not really your best self right now, that you're not okay? And if they can write some of those down, that kind of helps them like look at it and go, okay, maybe I need to use some of these strategies then. So what are those strategies going to be? First, internal coping strategies. So mindfulness activities. If they can, put on some music that they like, if they can access some that can help them. If they can find, TV to watch that can kind of help just to sort of put them in a different mindset. Anything that they can do to kind of help just sort of shift their thinking a little bit. Next would be identifying social supports. So you want to try to identify two different kinds. The first kind being just people you can kind of be around. If there's anybody that you can kind of talk to, if you can get up out of bed and find somebody. Doesn't have to be someone who you really lean on, but just someone you can talk to, engage in conversation with. Because when we're around other people, we're not focused on our pain or our discomfort as much as we would be if we're just laying there thinking about it 100% of our time. The second kind of social support that's important to identify is someone that they can really have a meaningful conversation with and kind of open up about like, yeah, I'm really struggling today. I'm really having a hard time today. Because that's a different type of social support. Both kinds are important. And so if they can identify someone or an area of where people usually are that they can go to just to kind of help, be around people, that's good. And it's even better if they can identify this is someone I can really open up to and talk to, someone who can really support me when I'm having a hard time. The other thing is identifying professionals to help. These may be doctors, these may be counselors that could be available. They could be our hospice workers. People who are, professionals who have training in managing some of these things and, really kind of know how to help people when they're feeling stressed out, uncomfortable, in pain, afraid, anxious. You have a different set of skill set than some of the people that they tend to just spend their general time with, and so it can be really important for them to identify this is a person, a provider who I really feel comfortable talking to, and I know that they can help me, and they usually help me feel a little bit better. The last thing that we kind of touched on today, but didn't spend too much time talking about, and that could be a whole other thing. If people are having thoughts about suicide, if they've identified a very specific way that they would attempt to kill themselves, and then we want to know, do they have access to those things? We want to talk about, okay, what are those things? Where are they? How do you have access to them? And what can we do to make sure that those aren't just there staring you in the face, readily available? Because the biggest thing we can do to help people not attempt suicide is to get rid of the things that they would attempt suicide with. And one of the most common myths about suicide is that, well, if we take away one thing, they're just going to turn to another thing. It tends to not be true. If people have a plan for suicide and involves something specific, they aren't just going to turn around and do solution Y. That's also why it's important to ask specifically, okay, do you have a plan? What have you thought about? Have you thought about any others? Because if we can eliminate all of those options, then it's very likely that they may continue to have these thoughts, but they are going to have a harder time acting on them, and that's going to give us more time to kind of work with them, provide support, and hopefully get them out of a place where they're feeling quite as overwhelmed and having thoughts about suicide. So with that, I'm going to wrap up there, and I just want to say thank you all for participating in this series, getting this information today, being a suicide prevention advocate from here on out, and more importantly, all of the really, really meaningful work that you're doing and the services that you're providing to people who really need them and deserve them. I just thank you from the bottom of my heart for all the work that you're doing in every way possible. And at some point, if I'm back, I'll look forward to sharing more knowledge with you. But that's all for today. Thank you very much.
Thank you, Doc, for an incredible presentation and the insights that you were able to provide to us that are working in hospice. I think that this will be helpful, and I'll let you know the kind of response we're getting from the folks who watch this, and we may need some follow-up. So thank you. I appreciate your help today in
Of
making this
course. Thank
happen.
you so much.
Okay.